I want to say hello to everybody who's joining us now. I want to thank you for joining us for this special edition of a webinar from the Pheo Para. My name is Robert Spelke. For those of you that do not know me, I am a member of the board. I'm actually the treasurer of the Alliance. But in addition to that, I'm also a patient. I've been with the NIH as a patient for now 30 years. I've had all sorts of tumors, glomus jugular, carotid body. I have tumors now inside of me. And I am a patient of Dr. Pachak, who's going to be joining us today. And you can see Dr. Pachak. This program is brought to you by the Pheo Para Alliance, whose mission is to empower patients with pheochromocytomas or parganglioma, their families and medical professionals through advocacy, education, and global community of support, while helping to advance research that accelerates treatments and cures. I like to say that that's the so-called standard definition, but I like to say that we're here for you, for the patients, the families, and the doctors. It's all about the people. I want to give special thanks to Progenics for making this webinar seminar possible through an educational grant. Today we're living in some strange times and we're all figuring this out together. Every situation is different depending upon where you live. We are thinking about our friends and family and the hardest hit places. For those of you that have stay-at-home orders, thank you for keeping our community safe. Our motto is here at the Alliance, we are stronger united. I want everybody to know we have another seminar coming up at 3 p.m. Pacific time, 6 p.m. Eastern time next Thursday. We also have a surgery webinar, which is scheduled for April 22nd. Please sign up for either webinar at the pheopara.org website. Also, while you're there, please sign up for our e-news and follow us on the social media. Our agenda today will be pretty open and flexible. In just a few moments, we'll begin taking question and answers from all of you, as well as some of the questions that have been submitted before, and we will ask those questions submitted. We're going to stick to questions related to the coronavirus and Pheo Para. Many people will ask variations of the same questions, so please listen carefully because the questions may be similar. We are trying to do questions that are less case specific and more general, which would be appreciated. The information presented on this webinar is for educational purposes only and should not substitute the advice of your doctor and medical team because they have in-depth knowledge of your medical history and current situation. Now it is my pleasure and to introduce Dr. Pachak. He's a board certified endocrinologist and an internationally recognized expert in the diagnosis and treatment of neuroendocrine tumors, especially pheochromocytomas and pargangliomas. He's a senior investigator in the section on medical neuroendocrinology. He founded the International Symposium on Pheochromocytoma and has authored hundreds of scientific peer review articles, books, book chapters, and books. And I'm going to open up the questions for Dr. Pachak in a very general sort of way. There is many categories of individuals, those with diabetes, those with lung issues, asthma, that are particularly vulnerable to this virus. Could you tell our community, are we as Pheo Para patients, or Pheo Para positive, I guess another aspect, are we considered at risk if we are to obtain this virus? Dr. Pachak?
Yeah, so first of all, I would like to say thank you for participating in this webinar. It's a really great pleasure as well as honor to be here today and to talk to our patients who, as you at least partially mentioned, are under certain risk, especially during this very complicated, I would say, unusual and new time for our society in terms of COVID-19. And because our patients that they have a cancer, and we know that there is actually some relation between the COVID-19 and cancer in terms of the incidence that can be much higher in patients with cancer, including pheochromocytoma paraganglioma. I think that would be very interesting to discuss some important issues, recommendations, precautions, and to answer some questions from our patients who are those who definitely may be hit by this infection. So here I am today, to answer those questions and comment about those questions, and also, if possible, to give some suggestions or some recommendations to our patients who are suffering from pheochromocytoma and paraganglioma.
Okay, so then, Dr. Patrick, are we at one of those at-risk in society, one of those groups that would you consider to be at risk if we were to get the coronavirus?
Yeah, so especially, patients with pheoparaganglioma, they are definitely at the risk. And if you take some, for example, some other cancers, they are also at the risk, and we know, and especially we learn a lot from China and from the population who actually was infected by COVID-19, that cancer patients had higher incidence and being infected by this virus. But if I go back to pheochromocytoma paraganglioma, it's definitely valid there. And why it's important? Because you have the tumor that releasing catecholamines. And somebody would say, what is the problem? Releasing catecholamines does not mean that we will be in the higher risk, but actually you are at the higher risk. And the reason is why you are at higher risk, because the catecholamines are affecting cardiovascular system. I would divide it into two parts. One is vascular system. Vascular system means, for example, the vessels. And you know that most of you having this diagnosis may have a high blood pressure. And high blood pressure is causing, if it is long-standing high blood pressure, is causing hypertension. And of course, we know that hypertension is one of the diseases listed under, those that are actually connected with COVID-19, which means that the group of people who have a high blood pressure are actually more susceptible to get this infection. So here we have the first example of the high catecholamines and the relation to vascular system causing hypertension. The second one is the heart, because if you have a high blood pressure, that of course the heart is pumping against the high blood pressure. You can imagine like you have a pump, and the pump has to actually pump the whatever it is here, the blood, but otherwise it would be water against something that there is a resistance. The resistance will be that the vessels are narrow, and then they cannot actually get a lot of blood. Therefore, the heart has to work much harder. If heart is working much harder, that sooner or later it will not work so properly, or some patients that may have heart problem. And again, we know that those that they have a heart problem, they have a higher susceptibility to get actually the COVID-19. The third one is that if you have a high catecholamine levels, you of course, and as I mentioned before, it's based on the effect on the vessels will be actually a little bit narrower, because and this depends on the hypertension, depends on many other mechanisms, and I will not go into the details. But if they are narrower, which means that they cannot actually pump a lot of blood, and especially to certain organs. And what we know about the COVID-19, the one of the organ that is affected and the most affected, because it is the certain type of respiratory infection, is the lungs. And the lungs, if they are affected with, for example, atherosclerosis, or the accelerated atherosclerosis because of high catecholamines and high blood pressure, will not have enough oxygen. And what's going on with patients that they have an infection with COVID-19, that they have a problem with the oxygen because the lungs cannot work properly. So, and contribution to that is if the vessels are a priori, so before or ahead damaged by high catecholamine levels. So there is another problem for patients with the pheochromocytoma in terms of the damage of the small vessels that are very important for the nutrition and blood supply of certain organs, and here especially lungs. So overall, I would say that the patients are definitely at the higher risk. And the last part is, I would say, what kind of medication they are using. Usually our patients with pheochromocytoma paraganglioma are on so-called antihypertensive medication. Antihypertensive medication, and most of you are on alpha, and some of you are on beta blockers. So if you have alpha and beta blockers, there are currently no reports that those patients would be at the higher risk. But however, some of you may be on another antihypertensive medication, and one of those antihypertensive medication is called ACE inhibitor. So angiotensin converting enzyme inhibitor. And we know that if the patients are taking this medication, that they may affect the enzyme that is directly actually related to the pathogenesis of the COVID-19 in relation to the damage of some organs. So overall, we have at least 4, but I would say even more mechanisms that are very complicated in terms of that the patient with pheoparaganglioma may be at the higher risk to get the COVID-19, and therefore they have to be very careful and to discuss with their physicians whenever they feel that there are some even very mild, I can tell you, really very mild symptoms and signs that could be related to COVID-19. I forget one thing, that all the patients with cancer, doesn't matter if it is pheochromocytoma, paraganglioma, or patient with breast cancer, colon cancer, melanoma, other cancers, they have a decrease the immunity. The immune system is not working properly. And how you can fight the infection? You can fight infection with different mechanisms, but one of the most mechanisms is actually to have proper function of your immune system. And cancer patients in general, and especially those who are on, for example, radiotherapy, chemotherapy, and I'm pretty sure that those who are today on this webinar may have some chemotherapy and radiotherapy, and they decrease the function of immune system, and it's very bad. So you have to be extremely careful.
Doctor, what about patients that have the genetic disorder, somebody like my daughter, but doesn't have any symptoms? Would they also be at risk?
Yeah, so if they have a genetic disorder, they don't have any symptoms and signs, I would dissect actually your question into 2 categories. So they can have a genetic disorder and they never develop any tumor. So they are under the category of being, for example, the pheochromocytoma paraganglioma susceptibility gene carrier. So they may or they may not develop the tumor, but assumed in the first category, they will not develop the tumor, or they did not develop tumor at the present time. there is no any study that would actually show that patients with some gene mutations as a carriers, which means that we have two alleles or two genes, let's say, make it very simple, one from father, one from mother. So if they are carriers, that only one gene or one allele, the gene is actually affected, but it's not affecting the second one. So they are usually living normal life. They are doing actually normally like everybody else, including, for example, physical activity, they're doing some other activities. So I don't think that they are at the higher risk at the present time. The second category are those that they have the mutation and either they had the tumor or they have currently the tumor. If they have a currently tumor, we already talked about it during your first question. And if they don't have they had the tumor before, tumor was removed and they are doing well, I don't think, and if they are not taking any medication, they will be like almost in the normal group of those. They don't have the tumor, they don't have any mutation. Maybe in the future we will find some mutations that are related to Pheo paraganglioma are not really good for getting the COVID-19, but we are far from that.
Okay, I thank you, Doctor. One of the questions I wanted to ask you is, can you talk a little bit about how your clinic at the NIH and how it's operating now because of the coronavirus? I could talk a little bit personally about that.
Yeah.
Because I got caught in this, and I know that I had my yearly scans done, and I was considered non-essential, which I'm happy about, by the way, as a patient at NIH, and we talked over the phone. And I guess some people would like to know, when do you become essential versus non-essential, I guess?
Yeah, so I think that this is the good question. So first of all, I would say that of course, our patients, or most of our patients, know NIH very well. I don't know if everybody who is on this webinar knows NIH, but I would like to say that we function as a clinical research institution. So we are not a very typical hospital, like, for example, we don't have an emergency room, and we don't have any subspecialties here at the NIH. In terms of the evaluation of the patient with pheochromocytoma paraganglioma, we provide, as you know, comprehensive evaluation. What is comprehensive evaluation? We look at the patients, we talk to them, we provide them with biochemistry, genetics, imaging, as well as treatment options. However, at the present time, because we are as a clinical research institution and we don't have, for example, the emergency room, so we would have a very hard or complicated time to put the patient, for example, not at the ICU, that would be okay, but if there would be more cases, that would be very difficult in terms of resources as well as support and the personnel. And so we are trying to work on limited actually schedule, restricted. And this comes to your question, what is essential, what is maybe semi-essential, and what is non-essential? So let's say we have a patient who actually needs the follow-up. That will be definitely the patient who can wait. The patient who had the surgery here a few weeks ago, and then supposed to come in the next 6 weeks. Yes, that does not need to be done because everything can be done outside. And we would not recommend it because the patient needs to travel, and you have to understand 90% of our patients are outside of Maryland, Virginia, and DC. So they would be actually in a complicated situation traveling from somewhere else, which would not be also in favor of the policy here in the United States with the social distancing and limiting travel. But there are patients who, for example, would call me and would tell me, look here, the doctor, I need some help because my blood pressure is going up and down. I have a tumor, newly diagnosed tumor. The tumor is sitting, for example, in the adrenal gland. I have really complicated situation. My blood pressure is 200, 220. I feel that I may get a stroke. Actually, I even had almost something like stroke. I collapse before. I have a nausea, vomiting, severe headache. Then after I have a high blood pressure, I mean the hypertensive crisis or episode, then my blood pressure is 80 over 60. I feel completely exhausted. I am almost collapsing and I need the help. And I cannot get the help somewhere where, for example, I am living, whatever the reason is, or I receive some help, but they told me they don't know what to do because they don't have experience. Not that they would not be good doctors, we have excellent doctors outside, but rather the experience is something that what counts here. So those patients, and especially with active tumor, where they have a very high catecholamine or metanephrine levels, would be definitely good candidate to come to NIH and to be evaluated. And we will be able to see them even that we are working on the limited basis. And we have a patient so that would be semi-urgent, close to urgent patient type. And then we have somebody who is very urgent. For example, the patient is calling us and saying, I was diagnosed with metastatic disease. Many of you were diagnosed with metastatic disease and not everybody will come. What does it mean to be, that patient to be under the urgent situation? It means that the patient will tell you, I am progressing rapidly and I need your help and I need to see you very quickly. And not only because maybe you would give me the therapy immediately at the NIH, but because you would tell me what you think based on your experience and long-standing experience, what can be actually the best treatment option. Somebody would say that can be done sometimes through, for example, Skype, Viber, or whatever we will be using. But sometimes cannot be done because we have to see the patient, we have to discuss with the patient, we have to examine the patient, because to make some recommendations from distance can actually lead to very serious medical errors. So we would prefer this patient, and especially with rapidly growing tumors, and those in liver and in the lungs, okay? So those patients would definitely need to see us, and we will be able to see them. And we will be able to do some imaging, and then actually to tell them, look here, we can do it either here at the NIH, or we will do it somewhere else outside the NIH. But I think that the patient will have a peace in his mind that, you know, things were done. He or she knows what will be the plan, whether it's going to happen at the NIH or outside the NIH. So, and then the last one would be something with very neurological, I would say, problems that, for example, some paresis, some very severe pain, that would be also problematic, some neurological symptom signs, the patient will be collapsing or having some other problems, and will be maybe evaluated outside, but would need some fast treatment, whether here or outside. We will be definitely happy, you know, to talk to the patient, and if necessary, even to be evaluated here.
Okay, thank you, Doctor.
Yeah.
Can you give us some ways to improve our immune system at all? Is there any way that we can improve our system and help us to fight out if somehow we come in contact with the coronavirus?
Yeah, so there are several I would say, approaches how to boost the immune system. Many of them are known and pretty, I would say, I'm not saying absolutely simple, but everybody knows them. Not too many of us are practicing those approaches, and I will actually list some of them or discuss some of them. The one is to try to avoid some situation that would be stressful. I know that easy to say, very complicated, difficult to do it, because you will tell me, oh my God, you know, we all know about that. It's easy, and how to do it. I know it's very difficult, but if you feel that you will be under some stressful situation, try to avoid the stressful situation unless you need to solve something very quickly. If you are under the stressful situation with your disease, treatment, some arrangement, how everything will be done, or you are not feeling comfortable, that you need maybe some input, some help, or your doctors are not answering, they don't comment, I'm offering you to definitely contact me. And some of you maybe know that I answer very quickly, and I will be happy to alleviate it at least a little bit. And I think it's very important, if you feel that you have somebody behind you who can help you with your disease, not absolutely cure you, but to help you, to give you, you know, some peace of mind that the treatment is there is a good plan. I think it's a big relief. The second is that everybody suggests that we sleep a certain number of hours. If you sleep 5 hours for 5 hours, because you have to do something that is never good, your system, your immune system will be eroded and will go down very quickly. So if there is any chance, again, it depends on your situation, depends what you are doing, what is in your family, but if there is at least option to sleep about 7 hours a day, so that there are some very good studies that show that between 5 and 7 there is a big difference. So about 7 to 8 hours sleep is very good. The medication, you can use some medication over the counter that boost the immune system, but overall we know that if you have a good vitamin C intake, that would be definitely beneficial. Fresh fruit, fresh vegetables would be something that I would definitely suggest. You can take the pills, whatever, you know, it's called Centrum and some other, you know, not absolutely sure if it is the best, but fresh vegetables and fruits would be the best. The second one is the vitamin D, that you should take good vitamin D, especially right now, because you have to understand that you are confined to your houses. Some of you may live in the apartment. That will be even worse because going outside will be complicated. Some of you cannot walk so well because you have either pain or you have some other problems that preclude you, you know, to do longer walks. So try to boost your vitamin D. You should take at least about 500 units per day. But usually it's the recommendation is from 500 to 2000. If somebody is, for example, obese, that I would definitely suggest to have a higher doses. Those doses can go up to even 2000 per day. And something in the middle would be about 1000. So, and it's really helpful because it's known that vitamin D, and it's not expensive, and you can get it over the counter with those doses, would be definitely very beneficial. And some also suggest, for example, to have a zinc to take on some regular basis to boost the immune system. This is the easiest way. And then on the top of what I said, if you go to certain stores around our area is, for example, CVS and some other stores, and ask a pharmacist or ask somebody from the store who actually has some view, understanding, they will make some suggestion of what can be actually taken on the top of what I said in terms of some immune system, like some boosters for immune system. I definitely recommend that. This is not any advertisement. I will not tell you what to do and what to take. And if you, some of you, if you contact me, I will be able to share you with some information. But what I wanted to say is definitely good, and some of you should take it, especially when you have at the present time that you have an active tumor, and if you have a metastatic tumor, definitely immune boosters on the top. Whatever I said before, you should definitely take it on daily basis.
Okay, thank you, Dr. Pachak. I believe it was Arnold Schwarzenegger that once said, if you can't sleep 7 hours a night, you should sleep faster. But I'm not sure.
You should sleep faster, but it's and one more thing I wanted to, if you can, of course, you may be limited, and I mentioned before, try to exercise. Exercise does not mean that you will do, marathon, or you will do something else. By the way, the marathon most likely will not be something that can be done just now, because of social distancing. But if you do walking or brisk walking every day, even 1 mile, 2 miles, it would be definitely good, or biking or doing some sport, at least for 30 minutes, or even if you can afford, I'm not saying you can afford, but for 1 hour would be definitely good plus.
Okay, thank you, Doctor. I believe you spoke about this, but we're getting some additional questions on this about blood pressure medications. Apparently, they're a bad mix with the coronavirus, and the Pheo patients rely on these to control their blood pressure. Do you have anything else to add? We had some other questions about what your thoughts are about this.
Yeah, as I mentioned before, you take the so-called ACE inhibitors, and some of our patients, not our patients who were actually examined or admitted, examined, and treated here at the NIH, because I never used the ACE inhibitors. So, which I said angiotensin converting enzyme inhibitors, and because they are definitely not good, and you have to stay away. Please stay away of that medication. Even your doctor will tell you, you have a high blood pressure, you have a pheochromocytoma, you need this medication. Tell them that you don't want to have this medication. I know that the final proof is still not there, but it's more leaning towards that this medication can be problematic, because then would increase actually infection in the lungs, and there are some specific mechanisms why it's actually happening. So, and there are many other medications that you can get, as I mentioned before, but as a pheochromocytoma patient who is in whom the tumor is functional, which means release catecholamines or metanephrines, or both, should be always on alpha blockers, and sometimes on beta blockers, and only if they have a very, very mild symptoms and signs, and the blood pressure is almost normal or slightly elevated, including slightly elevated heart rate, they can be all calcium channel blockers. Until now, to my best knowledge, until today, tomorrow it can be different, but until today, alpha blockers, beta blockers, and calcium channel blockers will not actually cause the increased risk for COVID-19 infection.
Okay. Somebody asked, I lost both adrenal glands due to pheos and depended on steroids. What do I need to know if I were to get the coronavirus?
Oh, that would be, if you get the coronavirus, first of all, the first minute you have to tell your doctor, because if you would not change your medication, or you would even skip your medication, because let's say you will get coronavirus, you will be a little bit confused, you will be under stress, you will not know what to do first, and you will forget to take medication. That can be disaster. Because if you don't have both adrenal glands, you have to be on daily medication using steroids. glucocorticosteroids and also mineral corticosteroids, but let's say the glucocorticosteroids are very important. And sometimes some patients are taking it once a day, sometimes twice a day. So you can imagine if you would get, for example, the infection with coronavirus, you will be in a complicated situation when you can easily forget. So the first thing what you will tell the doctor, even before maybe you start with coronavirus infection, that you may have it, because it's still unproven until you will be tested, you tell the doctor you don't have adrenal glands, you are on steroids, and you need actually adjustment of those steroids as soon as possible or whenever is needed. So going back to coronavirus. So coronavirus is actually associated with the infection. That infection is associated with the fever. And it's also associated with shortness of breath. Some patients, they have a stomach pain, they have a diarrhea, they have sometimes a headache and some other symptoms and signs. And finally, they may have a very bad breathing problem, including chest pain, shortness of breath. All actually the symptoms and signs or this situation absolutely requires that your doses will be adjusted. Adjusted means that the doses will be much higher, okay? And because if you would not adjust the dose, sooner or later you will be in the problem, not only with the coronavirus, but your blood pressure, heart rate would be, blood pressure would be low, heart rate will be pretty high, and will be very complicated situation that can actually be problematic the way that can cause serious consequences, even the death of the patient. So usually the doses can be increased by 50 or even 100%. And I can tell you if, for example, patients would be and unfortunately, it happens they will have a very severe infection that is, the third stage and maybe the fourth, stage, or, the part of the third stage is critical condition. Critical means that patients will need to be intubated. The doses of steroids are pretty high, and the patients are usually receiving steroids by IV, so intravenously, and they receive the steroids every 8 hours. This tells you how actually how much steroids you need, because in the regular life, if you are doing well, let's say you don't have any infection, you need, let's say in general, in average, 20 milligram of the steroids every day, maybe 25. It depends if you are tall. But let's say 20, 25. And if you are at the ICU and if the patient is intubated, they need sometimes 550 to 100 every 8 hours. So it's up to 300. So approximately 10 times or even more than the regular dose when you would not be sick. So you understand why during the actually process of the disease, duration, of the disease and the different stages, how the steroids will go up. So be very careful about that and always adjust the steroids, and also adjust as soon as you have some, let's say, breathing problem, fever, you immediately need to adjust the steroids, even before you get to the doctor, because sometimes you cannot get to the doctor the same day or in 2 days. Sometimes you cannot even reach the doctor these days. Not they don't want to talk to you, but it's a little bit complicated time, and you have to know that adjustment is very important, okay?
Okay. A follow-up question to the last adrenal insufficiency question. I've heard that there may be a hydrocortisone shortage. Can you speak to that at all?
No, unfortunately, I cannot, because this is beyond my scope. Look here, I am the one who is treating the patients and giving them the medication. I'm not the one who actually distributing the medication to the hospital. And I put this way, here at the NIH, if you would be my patient, And until today, I have not received any information that there would be shortage of hydrocortisone here at the NIH. So if you would be the patient today and you would call me asking for the medication, I think we would be able to distribute the medication to you. What is happening in different hospitals or even different states, I don't know. It depends who is manufacturing hydrocortisone, but you have to be aware of the fact that hydrocortisone is a very simple medication. It's easy to manufacture it. I doubt that this manufacturing hydrocortisone depends on only one company. There are many companies that they can do it, not only the US, also outside. So I feel that may not happen, but I cannot give you fair answer because simply this is beyond my scope of my work, although it's a little bit related to my patients who had the bilateral adrenalectomy. And I am notified sometimes if there is a shortage of certain medication, but for hydrocortisone, we have not heard anything until today.
Okay, it's my understanding, I'm being told, that the FDA has a website to track drug shortages due to the coronavirus. So if you have a concern about that, we encourage you to Google the FDA website and find out, search for the drugs that you may need and think are in shortages.
Yeah. So I think that this is extremely good suggestion. And also what we can do if the patients feel that there will be shortage of hydrocortisone and maybe some of you or few of them have the same information, send me email. I can call, I can talk to our pharmacy and ask them because they are connected with FDA and with other entities. And I will be happy to answer your emails after I investigate what is going on, because as I said, that would not be the answer only what is going on at the NIH, but we will get also the answer overall how the FDA is or other entities are viewing whether there would be such sort shortage or not.
Okay. Are there any contrasts that are used for imaging that reduce the immunity and therefore raise your risk for the coronavirus?
Oh, that's interesting question. I really not think about that quite a lot because we know that they can cause, some other problems. As whether you get a CT contrast, especially IV contrast, or the contrast for the MRI. But so far, I have to say that no. There are no any reports to my best knowledge that that contrast agent would cause some problems in terms of the immune system. So which means that they would actually suppress the immune system. Of course, we know that they can actually result in some reactions, for example, allergic reaction, or for example, MRI contrast, some fibrosis in lungs. So I would take it a little bit from different direction. I don't think that there is some specific effect of those agents on the immune system. However, you have to know that there are some description after the, for example, MRI contrast that could actually lead to some fibrotic changes in lungs and maybe some other problems, and those it can be problematic for those who could be actually exposed to coronavirus infection. I have not heard about any case or any scenario until now. Does not mean that it does not exist. But this is very interesting question, and I will need to investigate more about that, whether there is already something that, for example, somebody got the MRI, something, happened with the lungs, and then subsequently the patient was exposed to COVID-19 and to develop infection. I will investigate about that because this is very interesting scenario that is clinically absolutely relevant. Because as you know, and everybody knows in this country, we have so many CTs and MRIs, and the patient, they have access to so many imaging per year that something like that is definitely clinically, very clinically relevant.
Okay.
I will put it here. So the MRI and COVID-19. Okay, thank you for so much for that question.
Okay, my PET scan was canceled in March. I'm 1 year out from an operation and 10 months out from radiation, a 6-month full body scan.
Yeah.
This makes me uncomfortable. How do I know this is the right decision? And I guess on a more broader scale, and we talked about this during the last webinar. If you're doing MIBGs, if you're taking shots, I mean, obviously things are going to get interrupted, and patients now are feeling much more uncomfortable not proceeding with certain standard procedures or protocol. Could you first address that question, and then a more broader sort of question, and maybe bring up some of the topics that we discussed last time as well?
So, of course, under the protocol, and I understand that those patients who had, for example, operation, and not only operation, it can be, for example, treatment, whether it's radiotherapy, whether it's, for example, the chemotherapy, they're supposed to have a follow-up scans and to see what's going on. But the question was about the PET scan, and the patient is not feeling very comfortable, not having, for example, the PET scan, and that was scheduled and will need to wait. That's, of course, never good for anybody. Doesn't matter whether that would be, the COVID-19 infection period, or that would be everything will be over, we would cancel scan. Everybody who has or who had cancer scan is not feeling well because they would like to know what is going on in terms of responses. But I can tell you something. Even if the PET scan is canceled, we still have a CT and MRI. CT and MRI is, generally speaking, on many locations, wherever the patient or patients are living, and they always can substitute the PET scan. And I can tell you that CT and MRI are extremely accurate. Yes, in some patients may be suboptimal compared to PET scan, but still are not so suboptimal that we would see such very big differences. In other words, we would, if there would be some progression, CT or MRI would detect it. Would maybe not detect all the lesions, but this is not absolutely the point, because we know that there is, for example, progression, and patient needs either to continue or vice versa. For example, after 3 or 4 or 5 cycles, it depends on the protocol, would need to stop the medication. So PET scan for some, not for all patients with pheochromocytoma paraganglioma, it's sometimes more accurate in certain way. It depends what kind of pheochromocytoma, paraganglioma, etc. But because we have a CT and MRI, and they are still operating, at least what I was told by several patients outside the NIH. Sometimes we do them here as well, even during this period, but as I said at the beginning, has to be more on semi-urgent or urgent basis. If it is follow-up after the therapy, most likely we would not do it unless the patient would come with, for example, severe pain, suggestion that there is severe progression, very difficult clinical scenario, we would definitely do it. Also, I wanted to tell you, if you, some of you were operated, some of you will be operated, and no surgeon would operate on you only based on the PET scan. So the surgeon would operate you always, and and it's not only about one tumor, we call it solitary tumor. So multiple tumors that the patient is operating, always on CT and MRI, which means, or other words, CT and MRI is so accurate that if it is done well, and if it especially covers the whole body, can well substitute the positron emission tomography, which means the PET scan. So no worries if PET scan is actually delayed or was canceled. Yes, it's not optimal situation, and I understand it can be frustrating, but wait, it will be done as soon as everything is over, and we will be the study that will help you with maybe the final decision. We call PET scan sometimes as a complementary study. So we always prefer CT and MRI as the first study, and some of you, if those who visited NIH, you always have a CT or MRI, you never have only the PET scanning. So I think that we will be okay in this situation at the present time. Look here, this is not forever. Most likely we will open gradually in May and June. So I think that that's manageable, except for special cases, special situations. I mentioned about it before, and you are always welcome to send me email, and I will be happy to work with you, whether you qualify to come, for example, to our institution, and we will be happy to help you.
Okay, doctor. If, God forbid, one of our community were to get the coronavirus, and they are prescribed hydrochloroquine as treatment, is it safe for them to take it?
Yeah. So I don't have any experience with chloroquine, but I can tell you honestly that to my best knowledge, this medication is not listed as the medication that would somehow affect the pheochromocytoma paraganglioma from different directions. One is, for example, to promote the growth of those tumors, because of course we never studied it. We never actually look at it more carefully before. But from all the previous publications we have and listed, for example, what are can be side or adverse effects, as chloroquine is not listed as a medication that would promote, for example, the growth of pheochromocytoma or paraganglioma. And the second, when we look at the blood pressure and heart rate, because this is also very important for our patients, whether, for example, chloroquine could release catecholamines or and subsequently increase blood pressure and heart rate, it is not known. We actually look at the medication sometimes ago, not absolutely during the last several weeks, I have to be fair and honest, but when we write the articles, review articles, and summarizing medication that could be problematic for patient with pheochromocytoma paraganglioma, but never actually, or chloroquine was never listed as one of these drugs. But I will look at that. I promise to you, I will look at that because if there is something that published maybe 30, 40 years ago, but to my best knowledge, I don't think so, but I cannot say for sure, please, okay? I don't think so.
Okay, we're running short on time, so I'm going to ask this question, although it's not specifically coronavirus based. I have 6 inoperable paragangliomas, but my catecholamines are normal. I trapped myself at my parents' home in Mexico. That's a problem, I guess. I'd like to be in Mexico, but anyway, where the altitude is 7,000 feet. Will the elevation affect my tumors?
Oh, absolutely. So it also depends on what kind of genetic background is there. And we know, and it was published by very good scientists. One of the first papers came from Dr. Baisal, who actually also discovered the SDHD mutation. And it was really pioneering work in 2000. And there are some papers that are actually supporting that some pheochromocytomas and paragangliomas, and especially those they are under so-called cluster 1. Cluster 1 sometimes is related to those that are related to hypoxia. So which means that if there is more hypoxia, these tumors will grow even more, and the hypoxia environment is not the best for these tumors, which means that if you have a hypoxia outside of the body and then goes into your body because you are under low the atmospheric pressure, then of course you can with the low oxygen and breathing low oxygen, so you will have hypoxia in your body. It can be problematic. Just wanted to say that how the tumors, some tumors, some paragangliomas were discovered and discovered related to hypoxia was in 1970, I think, 2 or 73. Then in high altitude in Andes, actually patients, I mean, those who were living at the time in Andes, they had actually higher incidence of head and neck paragangliomas. And we know that especially the carotid body tumors are very sensitive sensitive to low oxygen. So I would say definitely yes. And then there are some specific pheoparaganglioma related to mutation like HIF2 mutation or prolyl hydroxylases or VHL that can also be problematic if the patient is living in hypoxic conditions.
And just to add to that, if you're in Mexico and want to go scuba diving, it's also a very high risk because of the pressure if you go underwater.
Yeah, so that would be that the information is not there in the literature to my best knowledge, but it would be also problematic.
Okay, thank you. The last question.
Really related to hypoxia. Okay, so, at the present time, this is the view that may be a little bit corrected in the future, but just now, related to hypoxia.
All right, the last question for this webinar. I do not have a Pheo diagnosis, but I'm sure I have it because of my symptoms. I've been in and out of the emergency room for months with no answers. Now I'm scared to go to the ER when I have an episode because of exposure to the coronavirus. How do I determine if I should go? I think you sort of covered this a little bit, but can you just sum that up?
So if I understand well, so you think that you have a pheochromocytoma paraganglioma, you go to emergency room, or you were at the emergency room, there was no any conclusion, and you don't want to go back because of the coronavirus infection, which I definitely understand. So I think that in that scenario, I think that it would be important to know what kind of tests were done when you were at the emergency room. I think that it would be for longer discussion. I would definitely suggest you send me information, and when you send me information, not only that you give me a very good summary, but also you actually attach the results from that emergency room or from any office that actually rule out or they were not absolutely sure you have a pheochromocytoma. Remember, you have to have the results related to plasma metanephrines and also catecholamines. The catecholamines not the most important, but plasma metanephrines will be definitely important. And then I will be happy to work with you and to give you some suggestion what to do and how to put everything together, because it can be also related to your medication, believe it or not, that can cause the symptoms and signs that would be sort of similar to having pheochromocytoma, but you may not have actually pheochromocytoma paraganglioma.
Okay, thank you so much, doctor. That was the last question, but I do know that, and again, just so that everybody knows, you have asked us to give out your email so that if anybody has questions, they can send it to you and you can respond. And it is Carl, K-A-R-E-L, at mail.nih.gov, G-O-V. So it's Carl at mail.nih.gov. And
yeah, it's my first name at mail.nih.gov. So everybody knows my first name. So, and if you then follow the rest, I think that it should be fine. I will be happy to answer your questions. And as I mentioned during the first seminar, I usually answer extremely quickly. So don't hesitate to send me your question, comments, suggestions, and I will be happy to help you. And also, to be honest with you, I'm learning also from you. It's a mutual interaction and exchange the information, and both sides together can do very good job, and we can have a very good outcome that goes mainly to you, which means the good treatment and helping you as much as we can, and also some other sites here at the NIH. I mean, not only at the NIH, but outside the NIH as well.
okay. Dr. Pachak, I want to thank you again for your time and your dedication to our patient community, not just our patients, but our caregivers and the other professionals that are working with this disease. I also want to thank very much Stephanie Albert, our executive director. She has put this together. This is the second one on short notice. It's a lot of work. She's done an outstanding job. This webinar will be posted on the Pheo website, so you can listen again. I ask again that you join us next Thursday at 3 p.m. Pacific time, 6 p.m. Eastern time for another coronavirus webinar. We do have another webinar on surgery, April 22nd. Again, sign up for our e-news and follow us on social media. And again, it will be available on YouTube as well as our website. If this information has been useful to you and you are interested in donating to the Alliance, you can do so at the pheopara.org/donate, our website. Thank you to everybody who's attended today for the outstanding questions that we got. I will send virtual germ-free hugs to all of our Pheo friends out there. Please stay safe, stay at home, and we will be stronger united. Thank you again.
Yeah, and I would like to thank everybody as well. Thank you to your Pheo Alliance for doing everything together. It was absolutely fantastic, and I like what you are doing for the patient. And I will be happy to participate next week. So if some of you and some new ones prepare some interesting questions, happy to comment. And as Mr. Spelke sent you virtual hugs, I am sending you also virtual hugs and wishing you all the best and deal with everything well. I know it's not easy for you because you are really in a complicated, difficult situation, especially having a tumor. But as I said, as much as we can do here for you, although we are just working on the limited basis, but soon will be over. So we'll be happy to help you and support you. And this is something what we like, and this is our mission. So be well and safe, and we will see with some of you and with Pheo Alliance next week on Thursday. Thank you so much.